So today we are going to study sickle cell anemia. So let us discuss the definition. What is sickle cell anemia? So it is basically anemia. So what is anemia? It is basically hemoglobin less than 13.5 in male or hemoglobin less than 12 gram per deciliter in female. So other way we can say that hematocrit is less than 41% in male or it is less than 36% in female. So okay, so it is a type of anemia in which the RBCs has turned sickle cell. Sickle cell. So what happens when RBC turns sickle cell? Basically, normal shape is biconcave. So this biconcave shape is more flexible. So it skips from splenic macrophages. So what happens to sickle cell RBCs? So they do not escape. So what happens? They are easily trapped, and once trapped, they are hemolyzed. So what happens when hemolyzed? So it causes anemia. So this is sickle cell anemia. So it is basically anemia where the mean corpuscular volume is normal range, that is 80 to 100 femtoliter. So we can say that it is a normocytic anemia. Normocytic anemia. Since there is hemolysis, so it is a hemolytic anemia. Hemolytic anemia. Since there is increased hemolysis, the body tries to increase the production. The body tries to make more RBC. So there is increased reticulocyte, which is usually greater than 2%. So now talking. So what basically this hemolysis is due to, we can say that, a defect in the hemoglobin. So it is also known as hemoglobinopathy. Hemoglobinopathy. So from this point, let us discuss what can be the cause and pathophysiology of sickle cell anemia. So basically, it is a hereditary disease. So how it is heredited? It is heredited in the form of autosomal recessive form. Autosomal recessive form. So what is the main defect here? It is a mutation. It is a mutation. Mutation where? In the hemoglobin. Hemoglobin where? In the globin. So globin has basically 2 alpha chain and 2 beta chain. So where? Beta chain. So in the beta chain, so amino acid sequence is there. Amino acid sequence. So in the sixth position, there is usually glutamic acid. In normal RBC, glutamic acid, which is substituted by a valine amino acid. So this is the substitution mutation, a point mutation, substitution mutation occurs, which gives rise to a condition known as sickle cell anemia. So after this mutation, the hemoglobin that forms, that hemoglobin is not a normal hemoglobin, which is HbA. It is known as HbS, that is HbS hemoglobin. So a person with, so let us discuss now what are the types of sickle cell anemia based on this HbS. So it can be like sickle cell disease, or it can be sickle cell trait. So let us discuss what is sickle cell disease and what is sickle cell trait. So here we come. So sickle cell disease means if a individual is homozygous, that means what? That means the individual's both allele is mutated for hemoglobin. So hemoglobin is a trait. So normally there are two alleles for this hemoglobin, for normal hemoglobin, which are HbA and again HbA. So HbA and HbA is normal. So if both are mutated to HbS, so HbS and HbS, then this individual is homozygous for HbS and he will suffer from disease. And if only one is mutated, so this is known as heterozygous. This individual is heterozygous and it is known as sickle cell trait, and he will have very mild symptoms. Mild symptoms. Okay. Now these are basically the two types, the disease and the trait. Disease and the trait based on HbS. So now let us discuss the pathophysiology. What happens here? How is the symptoms? How does the symptom occur? How does the clinical manifestations occur? And more. So basically, so pathophysiology. So once the RBCs turn to sickles, let's say sept. So what happens is, this is the shape of the RBC, sickle. So two things happen. One is hemolysis, as we already said, hemolysis. So hemolysis, due to hemolysis, what will happen? The content of the RBCs will come out. So like the content of the RBC, like LDH. So hem will go catabolism. So biliverdin, bilirubin will form. So indirect bilirubin increases. So what happens? Jaundice. So if increased jaundice, chronic jaundice for a long time, what happens? Pigmented gallstone. Okay. So next thing let's discuss. Another thing that sickle sept RBCs may undergo is Ruli formation. So what is Ruli formation? So it is basically sticking of RBCs over one another and forming a stalk. So it is basically sticking and like a coin, like several coins placed one over another. So what they do after doing, so let us discuss in which condition they can do this. So basically they can do this in the conditions of hypoxia. So what are the conditions that can cause hypoxia? Let us discuss. You can remember it by the mnemonics: hide hide in the cold. So basically one of the condition is cold. Okay. The other condition is hypoxia. I for infections. D for dehydration. Okay. So hypoxia, infection, dehydration, and cold can precipitate this Ruli formation. So when Ruli formation happens, so basically this is a vessel. They can occlude this vessel. So once occlude this vessel, the organ distal to this occlusion will suffer from ischemia. If the ischemia prolongs, there may be necrosis. So due to this ischemia, there will be pain, which is known as vaso-occlusive pain or crisis. So this is the phenomenon that is happening, ischemia, due to occlusion of a vessel. So now let us discuss what can be the clinical features of anemia. So the clinical features, basically the patient can present in two forms. One is in the chronic form in which the patient presents with anemia, symptoms of anemia. So what are the symptoms of anemia? The patient may have, depending on the severity of anemia, the patient may have just a simple weakness, fatigue, or a simple icterus, or gallstone, symptoms of gallstone if the anemia is chronic. Or if it is severe, there may be shortness of breath, there may be tachycardia or palpitation. So if the symptom is again more severe, the patient may present in syncope with confusion due to cerebral hypoxia, or may present with seizure. So these are the symptoms of anemia. Next thing, what we know, it can present acutely. So it presents acutely due to vaso-occlusive crisis. So vaso-occlusive crisis causes ischemia and it causes pain. Okay, so depending on the organ where it happens, where the ischemia happens, where the occlusion happens, the symptoms may be following. Like if the occlusion is happening in the digits, it can dactylitis. So that is painful swollen digits. Another thing, if it is happening in the penis, then it can cause priapism, that is painful swollen and erection of penis. Next thing that can happen in renal medulla. So basically renal medulla has decreased oxygen concentration. It is usually in the hypoxic state. So there is a high chance that in this part of renal kidney, there is a high chance that Ruli formation will happen. That will cause occlusion, ischemia, necrosis, and damage to renal medulla. So what is the function of renal medulla? To concentrate urine. So will the urine be concentrated? No. So the patient will fast dilute urine, also known as hyposthenuria, dilute urine. So its specific gravity will basically decrease. So next thing that can happen is the patient can have hematuria due to necrosis. So RBCs in urine. So next thing where the vaso-occlusion can happen, like spleen itself. So when the vaso-occlusion happens in the spleen itself, first thing is there is usually splenomegaly. So when there is splenomegaly, the blood supply demand has already increased. But once again, if the supply decreases due to occlusion, same as in myocardial infarction. If the supply decreases, then due to occlusion, then ischemia and infraction, leading to a phenomenon known as autosplenectomy of spleen. So that in sickle cell anemia, when there is a autosplenectomy, we have to prevent from infection with capsulated organism, like we need to prevent like pneumococcus, hemophilus, and meningococcus. Okay, right. Now let's move forward. So next thing where the complication happen in the heart itself, so leading to myocardial infarction. In the brain, leading to stroke. Okay, so depending on the organs, where like in the bone, femur head, leading to avascular necrosis of head of femur. So basically many joints pain, bone pain due to vaso-occlusive crisis can happen in sickle cell anemia. So next presentation can be a severe acute presentation, which is known as acute chest syndrome in sickle cell anemia. So what is acute chest syndrome basically? Let's talk about it. So basically acute chest syndrome is a condition due to infection, superimposed infection, mostly with mycoplasma or some kind of viruses. So basically the lung has pneumonia-like features. The patient can present with superimposed fever. The WBC count will be high and X-ray will show infiltrates. Sometimes this acute chest syndrome can happen due to fat embolism also. Due to involvement of bone. So secondary to involvement of bone, occlusion of bone, necrosis of bone, the fat can embolize to the lung and lead to acute chest syndrome, which is a emergency. Okay, now these are the basically presentations. Now let us discuss the complications of sickle cell anemia. So complications can be basically divided into complications can be so one is vaso-occlusive crisis that can lead to some complications like splenectomy, autosplenectomy, and autosplenectomy leads to complication known as infections with capsulated organisms. Infections with capsulated organisms. So next can be aplastic crisis. It is a complication. So in aplastic, basically here hemolysis has increased. So body tries to increase the production to compensate hemolysis. So when there is a event that suppresses this production, for example, infection with parvo B19 virus. So this is a myelosuppressant virus. It suppresses the marrow. So this production decreases, and since there is increased destruction, the patient can land in a plastic crisis, a plastic in which he may present with anemia, neutropenia, and thrombocytopenia. So features of all these three like bleeding, infections, and anemia can happen. So next complication that can happen is sequestration. That is splenic sequestration. So since there is a large spleen due to hemolysis, there's a large spleen, large amount of blood can pool and get sequestered in spleen. Pool in spleen. Since there is superimposed anemia, so anemia plus large volume of blood is sequestered in spleen. Splenic sequestration. Splenic sequestration. This can lead to sometimes hypovolemia, and which can decrease the cardiac output, which can decrease the BP, and can lead to shock. So this is again an important condition to identify in a patient with sickle cell anemia. Now let us discuss how will you diagnose. So these are basically the complications. How will you diagnose sickle cell anemia? So let us discuss the diagnosis. So basically we should start with CBC. So what will CBC? So it will show that there is decreased hemoglobin. Basically, mean corpuscular volume will be normal. There will be increased reticulocyte. Lactate dehydrogenase will be increasing. If this, so next thing is indirect bilirubin. Indirect bilirubin will be increasing, showing hemolysis. So next thing that we can do is the very next thing that we can do is we can do USC abdomen to see maybe splenomegaly. Okay. But the gold standard to diagnose sickle cell anemia is electrophoresis, hemoglobin electrophoresis. So what will it show? It will show decreased hemoglobin A, increased hemoglobin S, and again increased hemoglobin F, the fetal hemoglobin, which consists of two alpha chains and two gamma chains. So since there is defect in beta chains, the body tries to compensate it by producing more gamma chains. So there is increased fetal hemoglobin. All right. Now we need to know is a very important test that can be done is peripheral blood smear to diagnose sickle cell anemia. So on peripheral blood smear, what do we see is sickle sept RBCs. Sickle sept RBCs. So these are this RBC, sickle sept RBC, numerous, very important in diagnosis. Next thing that we can see is Howell Jolly bodies. So what are these bodies? So these are a RBC with some basophilic component in it. Basophilic component. So a part or remnant of nuclei. This is a remnant of nuclei. So usually RBCs are nucleated. So why this happens? This happens because body is trying to increase production. So some of the cells with this remnant of nuclei can occur in blood. So basically, it should happen in all hemolytic anemia, but it only happens in sickle cell anemia. Why? Why? Because in sickle cell anemia, the spleen goes auto-splenectomy. So when body is trying to produce more, it is forming some defective RBCs with remnant of nuclei, the basophilic component, and with superimposed auto-splenectomy, spleen is non-functional. Non-functional. So what happens when the spleen non-functional? Usually these type of RBCs in other hemolytic anemias were destroyed. But in sickle cell anemia, since the spleen is non-functional, cannot be destroyed. It cannot be destroyed, and it appears in peripheral blood. Peripheral blood. So did you get the concept? Peripheral blood. So what happens is these RBCs, remnant of nuclei in the peripheral blood, are known as Howell-Jolly bodies. So it basically represent non-functional spleen. Non-functional spleen. Very good. All right. Now let's move. These are the investigation that we do. So now, how will you treat a patient? How will you manage a patient with sickle cell anemia? So let's discuss the treatment part. So basically, the treatment can be for the chronic